in the mental health and behavioral health field for a little over 15 years. As we said, Recovery Options, just a little bit about our organization. We are the largest peer-run organization in New York State. We are actually celebrating our 35th year as a mental and behavioral health organization serving the 10 counties of Western New York. So not only are we the largest in terms of geographic location, but also we are celebrating close to 150 current employees, providing peer services throughout our catchment area. As a peer-run organization, what that indicates is all of our direct staff have lived experience with the mental and behavioral health services, whether that's navigating those services for themselves or supporting a loved one. As an organization, our vision is to ensure that everyone has choice and support in their recovery journey. And the Recovery Option mission supports people with mental health concerns, improving wellness, living independently with dignity in the community of their choice through peer-driven services. And that includes respite, recovery services, crisis stabilization, and supported housing. We like to say that, traditionally, models have integrated peer work into clinical services, and we are committed to kind of flipping that on its head. So we like to say that we integrate clinical services into our primary peer-run services. The model was developed, so we've been operating peer-run crisis respite as an organization for almost 10 years. And in Erie County of Western New York, there is a strong collaborative systemic group of providers meeting to really make sure that we're, on the whole, providing services to our larger community. So we are of the mind that our participants are also receiving services from other organizations. So we want to provide the best care that we can as a system to support that larger community. And from these conversations, we were recognizing that there was a need to have multiple services in one location, call it a hub, call it a center, a wellness center, if you will. It was really the recognition that individuals are utilizing different services for different needs, or at different points in their recovery journey, they may be looking for different services. They may be open and receptive to other services that could then lead to doors being opened for the possibility of additional services. And it was through these meetings that our former CEO, Dr. Kirsten Vincent, really came up with and spearheaded this notion that when we're having these locations together, somewhere people can go, they can interact with different organizations, find out what services are available, what services they're interested in, but really through this recognition that a hub like this, should be, and that there were benefits to it being peer-led, from, individuals who had walked through those same services, who had firsthand knowledge of the good, the bad, which services, were helpful at which points in their recovery, to really create that holistic, person-centered approach. And then it was working to determine which providers we felt made the most sense based on community need, based on finding partners whose mission vision aligned with what we were also providing. So our center encompasses 5 separate programs operated by 3 individual organizations. So Western New York Independent Living Center of Western New York, they operate a renewal center. It is a drop-in center. Participants can come, they can get an assessment, they can have a it's more of a open opportunity to speak with peers and to really find out what is available while receiving support. Our warm line is operated through Recovery Options. It is it is not 24 hours a day. It is 365 days a year. And it operates in the evening times when we were finding that individuals were not able to get in touch with their daytime providers, but still in need of having someone to talk to. We have our two levels of crisis residence operation. We are operating our short-term crisis residence, and we are hoping to open our intensive crisis residence within the next few months. And then we have a partner, Spectrum Health and Human Services, that offers some clinical engagement, some peer assessment, walk-in opportunities as well, and then some case management through them. In terms of our crisis residents, I'm sure everyone's familiar, with, as we said, crisis residences by different names. Our crisis residences are voluntary, they're peer run. We operate an up to 28-day stay. It is a very low threshold in terms of we're offering opportunities for that hospital diversion. So individuals who are identifying that they are experiencing a mental health crisis, yet not needing to experience an inpatient stay. They may not be looking for a medical model. They're just looking for some linkages, some supportive services to them, kind of taking them out of that immediate space. And then our intensive crisis residents will be hopefully more of a step down model. We'll have some nursing support there to navigate any challenges needed if someone has a medication change or those types of transition, going from a more intensive hospital setting to transitioning back into their own private residence. We're offering opportunities, for de-escalation of increased mental health symptoms, some supportive conversation, goal setting, wellness and safety planning. We utilize REP plans with, I would say, at least 90% of the participants that we're serving. Advocacy and linkage. So we're also working with individuals who are dissatisfied with the current services they're receiving, helping them to navigate a very complex system of care. Encouraging individuals to identify any services that they may or may not be aware of that could offer some continued support in their community, and then follow up. We always do 30, 60, 90, and 6-month follow-up phone calls with the participants that we're serving to make sure that those linkages, those referrals, those applications that were filled out during their stay, making sure that they have everything that they need to be successful back in the community. A lot of participants who will call to do intakes have identified that they are, kind of at their wit's end. They don't want to end up in the hospital. They've had previous negative experiences, and they're really self-identifying that they don't necessarily need that level of care, but they need that intermediate step.
Jennifer, we have a Q&A question for you. Are you okay with me asking you now, or would you prefer for us to wait till the end?
Sure, you can ask me.
All right, awesome. So Suzanne asked, what would we see happening in a crisis residential? Who would be doing what?
So in our short-term crisis respite, we employ peer specialists. So that specific residence that is not a multidisciplinary team. So the peer support specialists are doing treatment planning, they're doing assessments at intake, they are working on safety planning, they are really doing all of those things, advocating, collaborating with community providers. They are providing all of those resources. In terms of our intensive crisis respite, those the peer specialists would be doing that same thing. Any nursing staff that we would have would be providing more of that nursing education, any medical or medication teaching, in terms of we have some individuals who are either first-time diabetics and navigating those types of what goes along with that chronic illness, or individuals who, for whatever reason, haven't had that teaching just yet. We'd also be, the nurses would be providing that extra level of educational support, providing maybe some of that medication management bordering on administration, if only in the short term, for that teaching opportunity, how to fill a pill box, how to do those things so that when the individual is discharged, they would be able to maintain those habits in their own residence. In terms of so every state, in my understanding, has different regulations. That's when we're talking about that clinical component. We're not providing any direct clinical care. We actually, as an organization, have very few clinicians on staff. That is more for making sure that once we get beyond, or once we get to the point where it does become a clinical need, or individuals who are looking to seek respite, we are not providing a service or a clinical service that we're not able to provide. And so that's where that clinical judgment or that clinical determination comes in, not necessarily to provide a service, but to ensure the safety for both our participants and the staff, making sure that they're maintaining their peer role. And I can't see the chat or the questions, so please feel free to stop me and shout them out. We have found at the center itself, and as all of these programs taking their place in a larger care continuum, crisis continuum, again, as we said, every community kind of calls it a little bit of something different. It's really just making sure that all of our community members know that there's this vast service array, and depending on where they are identifying in their recovery journey, they're linking up with those services, those organizations that can best help meet their needs. So with that, really becomes this shared referral, this opportunity to really work as a group to determine, what services, if I'm working with an individual, I want to refer them elsewhere. So really looking to our collaborative providers. So self-referrals, internal center referrals, all of the programs are individual. So just because we're in one building, we're still doing that inner center referral. We're doing those warm handoffs. We're walking across the hall, checking in with everyone, our mobile crisis teams, our emergency personnel, whether that's police or EMS, and then our hospitals, so ERs and also inpatient units and the like, reaching out for those aftercare needs. The center, once we had the idea, or once the idea for the center was created, it was really determining where best in the community it made sense to house our services. We wanted it to be accessible to the individuals in most need, but also with identifying those areas where adding services to the area would be beneficial. We chose a location in the historic Fruit Belt community of downtown Buffalo. We're right on a bus route. We're not far from other outpatient collaborative providers and other coordinating providers with whom we were seeing a lot of referrals. And then it's really doing community outreach. So the building we purchased, or I'm sorry, leasing was a previous respite, but certainly needed a lot of work internally. So these are just some photos of the community outreach that we did to local grassroots organizations, local legislators, our current mayor, really reaching out to them to get the word out about the services, so that we knew that we were kind of creating this sense of community and belonging in this neighborhood. Early engagement efforts were to our local governing units, our key community partners, as I mentioned, those grassroots organizations, local foundations, and also our collaborative partners who were either already doing work in that neighborhood or nearby, to really get a sense of what was necessary. And then also the community members, the neighbors that we are seeing. So the building is in a residential neighborhood. We have houses on either side. We've made very good friends with the Waltons. They sit on our advisory board in terms of what they were hoping for in their own literal backyard. And then also, so the community advisory board with local stakeholders, the Fruit of the City or the Fruit Belt Coalition. We've been an active member in those community organizations, local block clubs. We've reached out to local churches. We participate in as many community events as we can, so people know what the services are being offered, and how we really feel that we can support the members of that neighborhood. And then just continued community outreach. So
Jennifer, can I jump in and give you a question that's been presented?
Of course.
Okay, so are RAP or action plans you mentioned being created in group, or are they more a one-on-one experience with your peer support?
We have found that our participants tend to do that work one-on-one. So at our respites, our participants are encouraged to, go out during the day, any activities or appointments, work. We have some individuals who will go and, engage in childcare, those types of things. So we have really found that those one-on-one individual RAP planning sessions have been more have been what participants have enjoyed more so than group activities. Group activity we find is more of the kind of friendship, sharing a meal, talking about how disappointed we are in the most recent Buffalo Bills loss. So we've really found that the group work or the camaraderie in that way tends to be focused less on those individual RAP plans, and more so on that fostering almost a peer friendship among our guests.
Awesome. And then we do have one more question, and then we'll have you continue on. Jeremy asked, when you have a person expressing suicidal thoughts at the crisis residential, how does staff typically respond? I have found that even the most seasoned peer specialists can get very nervous around this and may be quick to call 911. Great answer.
Yes, 100%. So we are assessing for safety, as I'm sure most are, from that initial intake call. And then, staff are trained to ask those follow-up questions, whether we're using the Columbia scale or using techniques from the assist model in terms of, let's talk through that. What have those thoughts look like? Are there any actions And then that's really where the piece comes in terms of working with the individual from the get-go in terms of their expectations and our expectations. Should those thoughts persist, worsen where they are, to make sure that we're providing the best support that we can. They are certainly difficult conversations to have, especially when, participants are saying or that they don't necessarily want to go to the hospital, but they're being open and forthright about the severity of the thoughts that they're having. Then we're really looking at, okay, it's not necessarily, we can work with that. We just need some commitment from those individuals as well in terms of if you're experiencing those thoughts, rather than kind of isolating in your room, come out. Staff are awake and available 24 hours a day. Let's talk through those types of things. And then just constantly assessing for any changes throughout the respite stay. We have unfortunately noticed or had experiences with those individuals that they've just identified that the thoughts were so intrusive that unfortunately their respite stay, they felt that they needed collaboration or an assessment from a medical provider. But we don't see that a ton because we're having those ongoing conversations and we're creating that safe space to have them. And then, for me with any staff, it's really supporting those staff through, even debriefing afterwards, having those conversations about what went really well, what maybe we could have done differently. We spend a lot of time at our staff meetings having those conversations, doing those role plays, talking about recent participants and lessons learned, so we become more and more comfortable with having those difficult conversations, and then ultimately knowing how we can best intervene and which skills to utilize during those conversations.
There was actually two follow-up questions that came in that are exactly the same, and they're asking, do you have your peers using the Columbia scale?
We do in some programs, not in all of them. We also it also depends on in terms of case by case basis. We have management staff available 24/7. So as we're starting to see that, that's when we're kind of pulling in those different assessments, determining what interventions we want to use. Like I said,
thank you.
because they are peer staff, so we're not technically, we're not conducting formal assessments. We are in the unique position of being able to kind of take those questions, take the different tools and utilize them in a way that works for our staff while they're still maintaining, while they're not providing any clinical assessment, if that makes sense. We're in the unique position to be able to kind of generate our own assessments.
Awesome. Thank you.
In terms of the center, that continuing that ongoing outreach, really making sure that we're connecting with our community providers and helping them to understand, in that same vein, what they can expect from all of our services. So when they're making referrals, they know that what they're sharing with the people that they're working with the participants of their own programs. We really want to be transparent about what we do, so we're getting those successful referrals back and forth. In terms of the center, we do have multiple funding sources. Our state office of mental health is our largest funder, our local foundation funds, and then some startup funds from the local legislature, which was very supportive in terms of the recognizing the need for these services in our community. Some pictures from our center opening. As I mentioned, the idea for this model came from our former CEO, Dr. Kirsten Vincent, who unexpectedly passed right after the building had been identified, and unfortunately before we could break ground. So the center was unanimously decided to be named in her honor, and it has been thriving in the almost 2 years that we've been open.
Someone did ask if you can say more about the picture with the governor.
That was our one of our CEO and one of our collaborative partners in at Advocacy Day. So they had the opportunity to share with the governor what we have been working on in terms of creating this continuum of care, this truly collaborative model that we'll get into a little bit more since that picture was taken, what we've developed as a community in terms of really a hospital diversion system. So we kind of call it our crisis continuum collaborative, and it's a bunch of organizations that have since worked together, have had more meetings with the governor in terms of the need for all of our organizations to work together collaboratively to ensure that our community as a whole has access to this wide array of services that ultimately, keeps people in their community of choice. So that was the picture with the governor.
Great, thank you.
And then in terms of one of our programs that we did, again, to get that community buy-in was, as anyone who has decorated in almost 1,100 square foot space knows, we need art to hang on the walls. So we utilize this as another opportunity, not only to reach out to the community, but also to recognize the value of art in recovery, not only as a coping skill, but also in terms of making our respite the home-like environment that we want it to be. So we worked with local artists, we worked with local public schools to get children's art hung on the walls that all of our guests can enjoy in their, not only throughout the shared spaces, but also in the bedrooms of the respite, to really have that calming opportunity. And then also to hopefully inspire hope. A lot of the artists that we purchased work from identified their own recovery journey, and that was really powerful, not only for them, but also for the guests that we're serving, who get to enjoy the art every day. We're hopeful in terms of transitioning that into program at the respite. So utilizing funds for potentially a coping skill coloring book, maybe bringing in some community providers in terms of art classes, either locally or at our Kristen Vincent Respite and Recovery Center, to provide our participants with those tangible coping skills that they can utilize when they return home, and also to identify those services and those things they can include on their RAP plans. We also, through our residents and through this project, we're committed to developing a peer workforce from the local community. So we created an employment mentorship program assisting individuals to successfully complete their peer certification and hopefully pursue a peer work as a career. So not only with our organization, but other local organizations that employ peers as well. And this is actually this gentleman's name is Joe. He was a former participant of our programming who, through his recovery journey, now works for our organization. So. And then in terms of, for this program and also our outcomes, in addition to the respites that we run out of the Kirsten Vincent Center, we also have a second short-term crisis residence that we run in Jamestown, New York. So, both of those programs see a 95% hospital diversion record, and also a 71, now that the colder months are here, probably closer to 70 to 85% utilization. Each short-term respite only has 4 beds, so we do typically have some level of wait list at any given time. But these these outcomes are just for our Kirsten Vincent Center. But in terms of the first 18 months of its life, we saw 188 individual guests and over 200 individual stays. So one thing we saw was that there are a lot of first-time individuals who had never had access to our services before, whether it was because they didn't know about them or couldn't get to us. So we're actually reaching out to a lot more individuals in the community, which has been really great. And then unfortunately, we only have a percentage of our beds open because we have yet to open our intensive residence, but soon. And then in terms of this specific model replication, wherein we have multiple services, multiple agencies under one roof, it's something that we've worked with internally, kind of with our model, looking at that with collaboration. So identifying other organizations that we want to partner with that make sense for the community need. Customization, so we're not necessarily going to be opening the same services all under one roof. For example, in Jamestown, our respite is a standalone building that we own. So when we're looking at replication of models, we'd be looking at, does it make sense to house an intensive respite with a crisis stabilization center? Or we're looking to operate a recovery center in the evening hours, similar to the renewal center that I mentioned, in terms of it being a walk-in model with multiple professionals available for assessments or linkages to workforce and the like. So what makes sense in those instances? And then really keeping that continuum in mind. So when I'm identifying that I'm experiencing a need, do I need a warm line? Do I need a crisis respite? Do I need a case manager to come and see me? Where in my recovery journey am I? Where I'm going to be receptive to the services that are available. I didn't realize that was the last one. So I did want to just point out, as I mentioned briefly, we have locally in Erie County Crisis Continuum Collaborative. So it's really those organizations that offer different types of crisis supports. So a stabilization center, a crisis respite, a call center, case management, and representatives from all of these organizations are working together with a strategic planner through a local foundation to really make sense of what services we have available in our local community, and then getting the word out to community members who may not know what is available. They may have never needed assistance before. So working with our providers to make sure that our community is aware of what is out there, how to get in touch with the providers that they need, and what services each organization offers. So it's kind of that no wrong door idea. And that truly comes with, first and foremost, us as community providers and collaborators knowing what we have and working together to make sure that we're sending the right information out into the community. And I think that was think there may have been a couple questions that popped up, but I can't see.
We are open for questions, so please feel free to put questions in the Q&A. Oh, we got one. Ruth said, regarding the slide on outcomes, do you have data on what's your services help the participant to keep? For example, after receiving your services at the peer respite, they have kept their job or have a more positive relationship with family or their children.
So during our follow-up phone calls, we do, we do ask the participants or the guests that we've served with whom they're working still, what the outcome was any referral that were made. We find that those ongoing phone calls really produce more qualitative, anecdotal, anecdotal stories from the guests that we serve, in terms of, I was struggling with my loved one and things are better now, or things are not better now, those types of things. We keep track of referrals that are made, and then we get more anecdotal or qualitative measures in terms of what is still successful.
Leanne asks, thank you so much for your presentation. How does your center provide cultural focused supports and or language barriers?
Sure. So in terms of language barriers, we utilize a telephonic translation service that that staff can utilize with individuals. And then in terms of cultural, being culturally aware, culturally sensitive, first and foremost, that started with wanting to staff the center with individuals from that same, the same community that we're located within. So that's really first and foremost how we address that. We do, during our assessment phase, ask our participants for any cultural considerations that they may need during their stay. And then it truly is fostering that air of open communication and dialogue in terms of that, mutual respect and education among both staff and all of the guests that we're serving.
And we have one from Jeremy. He said, your crisis residents are licensed through OMH, which I'm assuming is Alms House. And what was the process of doing that like?
So both of our short-term crisis respites and technically our intensive crisis respite is licensed through the New York State Office of Mental Health. So our short-term crisis respites were already operating prior to licensure. When we decided to pursue licensure, we kind of married our existing program with the New York State regulations in terms of intake, in terms of admission, in terms of discharge planning, all of those types of things. So it wasn't that big of a leap. I say that now, it felt like a bigger leap at the time. But in terms of, recognizing that we were already providing the service in an expert manner, really just making sure that we were, we did incorporate any New York State regulations. We had our site visit approximately a year ago. So yeah, we maintained that through the Office of Mental Health.
I just wanted to put a plug that Ruth said in the chat that you have a wonderful and supportive program.
Thank you.
Do we have any other questions? All really good questions that were posed forth. I guess for me, Jennifer, I would love to know, what is your favorite part about your program, and what is the part that you hope to improve or change in the future?
Sure. So my favorite part of our program is getting to see our peer companion staff work with the guests that we serve, um, to really help them, help the guests that we're serving achieve those short-term goals that they set out, to do when they are at the respite. Obviously, we are with our participants for such a short period of time. And for me, it's most rewarding seeing staff get to realize, and support and celebrate the guests achieving whatever goal it was that they had, that the staff helped them to achieve. So right now, we're seeing a lot of longer term goals. Housing is a huge thing that we struggle, within New York State, that I know is obviously a nationwide, issue, but really help getting to see staff celebrate those successes. And so it's a success for the guest, but also a success for the staff that helped them achieve that goal. That's truly what the magic is. And then having that participant call back during their 30-day follow-up, or, seeing them, if they're still visiting the renewal center, a couple weeks later, really making that connection, making that bond. And then I think the most difficult part about what we're trying to do here truly is finding that place in the continuum. So really working with those collaborative partners in terms of determining where we all fit best, and committing to one another to continuing to have those ongoing conversations, to make sure that we're not, or I can't say that we would never not, but that we're minimizing the opportunity for any of the participants that we're serving to kind of fall into that proverbial crack, or to unfortunately leave us without some sort of support. And so it's not necessarily my least favorite, but it's certainly, a challenge that we keep working on, every day, and we certainly have successes in, but it's definitely something that we continue to work with, making sure that our other providers understand what we do, and how we're able to assist.
Absolutely. I'm sure some of us can certainly relate to that. Jenna had asked, I am wondering how you ensure that peers know the respite resources are there for them and gain trust for it to be used.
So in terms of our outreach, that really comes from outreach. I think, working with those collaborative partners, working with other programs within our organization, who, if they are working with someone, reaching out to our staff, reaching out to them to really foster that understanding of what services we can provide, to that individual with regard to what they're going through. I think trust is gained through transparency as well. So providing feedback on what we can do, and answering questions about what we're not able to do, what our program does and how we're able to help, but being as open about, what our limitations are as well. To me, that's where the trust is gained. I'm not going to promise something that I can't provide, and then ultimately making sure that we're delivering on what we say we can.
Awesome. That looks like that might be the last of our questions. Of course, if you have any more, please put them in the question chat. But
Sure, I
you know,
can also, I'll just throw my email in the chat, and it says host, and there we go.
Wonderful.
Well, Jennifer, thank you for such a great presentation. This has been a wonderful way to kick off our year here. And folks, if you are not familiar with CRA, you can learn more about us at crisisresidentialassociation.org. Our next webinar will be in March. Our member support call will take place in February. So in addition to the listserv, we'll also post some of those notifications through our LinkedIn, Instagram, and Facebook channels and pages. So make sure you watch for that. Thank you so much for attending, and we will look forward to seeing you at the next event, and we wish you a wonderful rest of the week. Cheers.
Thank you.